Thank you for joining me this evening. So as you know, this is the third meeting this year, and we are still answering some questions from only one experience. And we have at least today two of the faculty staff, Professor Vijaya and Professor Kaushik. So welcome, and I would like also to welcome all new participants today. We shall start now. And so before I start, now it's time to practice, to share our knowledge and experience, and also our thoughts. And above all, I hope we can all learn with pleasure and with fun. So now we will start by something sweet and sour. And this is a clue for you, Dr. Sahana. So first of all, you are in India. So what is the ambulance number or hotline in India?
101, ma'am.
Okay,
Yes.
good. So as you know, Dr. Sahana and everyone, it's called the General Medicine Station. Not all of the questions are about general medicine. Some of the questions are emergency, like emergency situation, and others like cool questions, like for example, what is the effect of smoking of the eye? What is the definition of diabetes, hypertension, side effects of some drugs? But today we'll see what we have today. Today I'm gonna show you something different. So you will hear a scenario. So it's not my voice.
A 20-year-old man is brought to the emergency department with abdominal pain, nausea, and vomiting with increasing polyuria, polydipsia, and drowsiness since the day before. He was diagnosed with type 1 diabetes 2 years previously. He mentions that he ran out of insulin 2 days ago. How would you manage this patient?
So all the symptoms which have been stated in the audio looks like a case of diabetic ketoacidosis, ma'am.
So one second, Dr. Sahana. So I want to test your, let's say, your listening skills. I will repeat it again, okay?
Yes, ma'am.
This time I want you to re-memorize what she said, okay?
Okay.
A 20-year-old man is brought to the emergency department with abdominal pain, nausea, and vomiting with increasing polyuria, polydipsia, and drowsiness since the day before. He was diagnosed with type 1 diabetes 2 years previously. He mentions that he ran out of insulin 2 days ago. How would you manage this patient?
Okay, start now.
Ma'am, so she said the patient is a case of type 1 diabetes who has not taken insulin since 2 days, was diagnosed 3 years back. He has symptoms like abdominal pain, nausea, vomiting, polyuria, polydipsia.
Okay, now this is a paragraph she was saying.
Yes.
So
Yes, ma'am.
to compare what you have said with what she was saying.
Yes, ma'am.
So you recalled all the information except the numbers.
Drowsiness. Yes, ma'am.
The most important now to focus on the question. How do you manage this patient? How would you manage this patient?
Okay. Ma'am, I would like to, the patient is conscious, is little drowsy. So I would like to check for his airway is okay and breathing, and to check for SpO2, oxygen levels, and also to look for circulations like pulse and BP. And also I would like to look for dehydration signs.
One second, Dr. Sana. So as you know, in this practice, we can interrupt you.
Yes.
So please don't say abbreviation. So like BP,
okay.
Say blood pressure, please.
Okay, sure. So I would like to check for the blood pressure, and I would also check for the saturation of oxygen. And I would like to see if there are any signs of dehydration present, like skin, if there is any dryness, and the skin turgor is lost.
Okay,
and also the tongue.
You spent a lot of seconds. So you remember last time, before the last time, the first meeting, we said A, B, C, D. So D, like a mnemonics. We don't say mnemonics in the exam, but you already started describing your mnemonics A and B and C. So please, buzz this like alphabetic order. Say D. So do you remember what I said about D?
Yes, ma'am.
Don't forget glucose. So
okay, glucose.
So because this is all about glucose
Yes,
level. So,
yes,
yeah.
Yes, ma'am. So I'd also like to check the blood glucose levels, and
it's found to be like 500 milligram per deciliter.
Yes, ma'am. 500. So glucose levels are high. So and also, so it could be a case of diabetic ketoacidosis. So I would start the patient on fluids, mainly first to correct the fluid deficiency. 1 liter of 0.9% saline over 1 hour, and also check for the BP. If the systolic is less than 90 millimeter of Hg.
You said again the abbreviation.
Okay, ma'am. Sorry, blood pressure. I'm sorry.
We are practicing. Yeah.
Yes. Blood pressure is less than 90 mm of Hg. Then I would also give additional fluids, 500 ml, and also take the investigation. I would draw the blood to see the pH, and for blood glucose, urea, electrolytes, full blood counts, and also
so what do you mean by
levels.
So what do you mean by pH here?
pH of the blood, ma'am.
Yes, it is under the heading of one investigation. So what is the name of the investigation? It's a kind of
ABG.
Yes, you have to say ABG. Okay, ABG to check for pH and others. What others in the ABG? What other parameters like data in the ABG? Because the pH
bicarbonate
here is
levels.
Yes, bicarbonate level. Okay, and it found to be low. So the pH is like, let's say something like 7.2, and the bicarbonate level is low. So now.
Now, I mean, I would like to add on insulin first, because the insulin, I mean, the level blood sugar levels are around 500. It's been mentioned. So I would like to add 50 units of human insulin to 500 ml of.
So there is a missing point in the investigations, because if you are going to give insulin right now, so you are like sure about your diagnosis right now. It's diabetic ketoacidosis, right?
Yes, ma'am.
So still there are some points in the investigations, because if you are going to give the insulin,
blood ketone, okay, ma'am, urine ketone levels and blood ketone levels.
Yeah, and they found to be positive. But now, if you are giving insulin, so the insulin helps to decrease the glucose and also the potassium.
Potassium, yes, but urine and electrolyte level will be sent. So if potassium is well within normal limit, more than 3.5.
So have you said potassium in your workup?
Ma'am, yes, ma'am. I mentioned like blood urea and electrolytes. I didn't mention it. I mean,
so you have to name it specifically, because potassium level is important before giving insulin. Because it's the potassium.
Okay.
So don't say like ABG and that's it. You have to specify, I want to check for pH, for bicarbonate level, because this is all about acidosis, ketonemia, and potassium level, glucose level. Okay, so the difficulty in this question is about the lab, actually. So this step is the most difficult part in this question, actually. So keep going.
Okay, so I would like to give patient the insulin by after seeing the potassium levels, if it is within normal limit, 50 units of human insulin to be given in 50 ml of 0.9% saline, and then it's a bolus. Then you can infuse regularly 0.1 unit per kg per hour. Then you have to keep checking for blood glucose level every 20 minutes. And titrate the insulin, and also the electrolytes has to be checked for. If potassium, especially the potassium, if the potassium level is below 3 millimoles, 3.5 milligram per deciliter, then potassium has to be supplemented.
Okay. So in the workup also you have to check for the triggering factors, like the precipitating factors. So here, according to the history, mostly because of the missed insulin. So because he ran out of insulin 2 days ago, but
yes.
Even though you have to search for like one of the most common trigger factors, infection. So you have to search for infections. So in examination and sometimes and investigation also, you might order chest X-ray to rule out chest infection. And again, you can add in the investigation ECG. Okay.
Yes. Okay, ma'am.
Anything more?
Yeah. Then if the ketone, if the bicarbonate is also elevated, it's very less, then we can replace bicarbonate as well.
Okay, so some practitioners don't recommend saying this because this is like a dangerous line of treatment. So you can also add you need to hospitalize. So this is like logical, but you have to hospitalize and better in the intensive care unit.
Yes.
Okay, thank you, Dr. Sahana. And
thank you.
Let's say Dr. Vijaya, if she wants to add something.
Yes. Okay. In the investigations, please add clotting profile, because this is a hypercoagulable state with fibrin platelet aggregation that is possible. So low molecular weight heparin should also be added in your line of treatment. Also, what is important is how will you prevent similar crisis from happening again, because he probably is a young diabetic. So you will have to counsel him heavily and tell him to take his insulin regularly, keep a good stock of insulin so he doesn't run out of it, and supplement it with walks and exercise and a good diet plan, and monitor the blood glucose, have a glucometer on hand, and modify your insulin depending upon the sugar level, and also check for ketones. So you can titrate your insulin requirements according to the stress levels or illness or infection. And patient should never stop taking insulin. That is the actual message that has to go to the patient. Never stop taking insulin.
Okay, ma'am.
Yeah. Okay.
Thank you, Professor.
Yeah.
Thank you.
Yeah. Thank you.
Valuable comments. So back to Dr. Sahana. So according to this scenario, it's type 1 diabetes. Okay. And as Professor Vijaya said that a diabetic patient should keep on insulin, because a common scenario is that the patient with loss of appetite due to like infection. So this patient may thought that there is no need for insulin since there is no meals. So this provokes an attack of DKA. But if type 2 diabetes could present with like DKA also, or it's only for type 1?
Even the type 2 can present with DKA.
Okay, so
but it's more common in type 1.
So it's more common in type 1. This is why the scenario here, this is an actual scenario from an article. So it is in type 1. So you have to know also the symptoms of DKA. So we can summarize the symptoms into 3 categories. So as you can see here, we have polyuria and polydipsia. These are symptoms of diabetes in general, but they are more severe in DKA. And we have also, let's see, here's the pointer. And we have abdominal pain and nausea and vomiting. This is due to ketoacidosis. Okay, so again, in your examination, you have to exclude, it could be like surgical abdomen or like acute abdomen. So how do you differentiate between, because this is like GIT symptoms, how you differentiate between this abdominal pain from surgical abdomen, like something needs surgical interference, like intestinal obstruction or appendicitis or something like this? How can you differentiate in examination? Because here the first symptom in this scenario is abdominal pain. Okay, we will see in a moment. So we have like GIT symptoms of diabetes, and also drowsiness. So we have disturbed level of consciousness because of acidosis and so on. So the case can be presented in the form of coma or loss of consciousness, but here he is just drowsy.
Yes.
So the scenario here already mentioned a brief history, but imagine the case is like one title, one sentence. You have to say in your assessment, I have to take a brief history before starting my management. So what's the meaning of brief? Brief means it should be like concise, very quick, and very relevant to the situation, this situation.
Yeah.
So this is what what I just said. So the symptoms of DKA is like of diabetes, but severe. And we have GIT symptoms, and we have maybe coma, or the patient is shocked because the patient is dehydrated, as you mentioned in your assessment, because of loss of fluids.
Yes.
I posted this video, and so you forgot this in your assessment because you have to check the respiration. I think you didn't say it. Because
Yes,
this is
ma'am.
very characteristics of DKA.
Person was breathing with ketotic smell.
Yes, let's see. So here, this is from the YouTube, but so I did some camouflage to mask the identity, but anyhow, you can see his chest. This is this child with diabetes type 1. So can you describe what's the name of this type of breathing, Dr. Sahan?
Cosmos breathing.
Cosmos breathing. So this is like the name. So can you describe it? Is it right, rapid or slow, shallow or deep breathing?
It's rapid and deep breathing.
So it's rapid and deep. And sometimes in the scenario, they may say, the examiner may say, the patient has like a sweet or fruity smell of his breath. This is also pathognomonic of DKA.
Okay, ma'am.
So let's see the assessment according to the article and try to see what you have missed.
Temperature.
Okay, so first, at admission. So it says that this patient should be admitted. So I want you to comment on everything in every sentence. So what about the blood pressure?
Blood pressure, it's on the lower side, ma'am.
Okay,
hypotension is.
Yeah, it's like a borderline hypertension. How about the heart rate?
There is tachycardia, which is present.
Tachycardic, respiratory rate.
Tachypnea.
Yes. And temperature?
Temperature is
normal. It's normal.
Normal.
So what is the significance of checking the temperature?
Could be any infectious.
Yes. Yeah, if it's high, it may suggest infection. And actually, in this video, on YouTube, this child has like tooth infection, something like this. And you have to know the normal range for each of these points, like what is the normal blood pressure, heart rate, respiration, temperature. Okay.
Yes.
So among the point to be assessed is the mental status of the patient, and he's drowsy, as in case. So the next one, so as you can see, the comment on the respiration. And here's the sentence I highlighted in yellow here. This is how we differentiate between like medical versus surgical causes of the abdominal pain. So in medical causes, we have tenderness without GERDing and without rebound tenderness. So if there is a GERDing and rebound tenderness, this is a surgical abdominal cause for such pain. Okay.
Okay.
And this is like a basic medical or basic knowledge. I think you remember it right now.
Yes.
And here's the lab, which is the most difficult for me because I don't know, but you have to know the normal range for blood glucose. So this is definitely high. Okay. And you have to know the normal pH. So as you can see here, it is arterial. So you have to stress on the point of ABG, and like we have to check the arterial pH. So can you comment on this number?
It's 7.24, ma'am. Normal is 7.3.
Yeah, so this is acidosis.
Acidosis.
And what about the pressure of the carbon dioxide here? So it's like 35, because now I'm reading from the comments below the slide, because it's hard to remember all these numbers. Because if you said this is normal, so this is against your diagnosis, because it should be like low. So the normal from 35 to 45. So here the CO2 normal from 35. And how about the bicarbonate?
It is low.
It's low. What's normal?
20.
So it's 22, yeah, 22 to 29. So it's low. So this is support your diagnosis. So the bicarbonate is low because this is metabolic acidosis. CO2 is low because of the breathing, because there is a washout from hyperventilation. So we have leukocytosis. By the way, leukocytosis could be due to infection or due to DKA. So DKA per se can cause leukocytosis. So we have leukocytosis. And
Yes,
as you can see, we have ketones strongly positive. So what is the importance of checking you said we have to check the creatinine and BUN. What is the importance of this?
Yeah, acute kidney injury.
Yes, we can get like acute damage to the kidney. Okay, excellent. Well done, Dr. Sahana.
Thank you, ma'am.
And this is taken from this website. So again, I think the most difficult is to memorize all these numbers.
Yes, ma'am.
So,
ma'am,
yes,
I have one doubt. This, usually it's like milligram per deciliter. That's how we mention about the glucose levels, no, ma'am, generally. But in many of the handbooks, it is in millimoles also. So should we memorize both the things, or how is it, ma'am?
No, I think a milligram per deciliter, because this is the most practical. Like,
okay.
So in my hospital, we use this notation. So we have 3 lines of treatment: fluids, insulin, and potassium if needed. So I don't like mnemonics or any abbreviation, but I like my own. So can you summarize what I wrote in this slide? So let's comment on the first column here. What does it mean, this column?
Is it that airway, breathing, and circulation?
So why I wrote like C in like a big font, the biggest font here?
Because the fluid hypotension can be present.
So because this is the most important here in our case. Circulation is the most important. But suppose you have a case of shocking or like fits. So the priority goes to airway. Like airway. Okay. And let's see the next column. ABG stands for
arterial blood gas.
Arterial blood gases. So you have to know the data of the arterial blood gases. And the third column is what we are talking today, so DKA and diabetic ketoacidosis. And this last column here about the line of management. And as you can see, we have potassium here and K. And that's it. All right. There are some additional investigation regarding the infection. You may use, like, you order blood culture, urine culture, again, to search for a source of infection. Okay. So, Dr. Vijaya, do you have a last comment on this case before we shift to our beloved ophthalmology?
So I would say that for every patient, you must mention ECG. Okay, the student didn't, but Dr. Ghada, you told her to write ECG also as one of the investigations, because as you know, most diabetics would have a silent infarct, and that is why ECG is very important. Don't miss out on that investigation at all.
Okay, thank you.
And also remember a few points about hyperglycemic, hyperosmolar, non-ketotic state. Nowadays, it is called HH syndrome. That's it. Hyperglycemic, hyperosmolar syndrome. Okay, just a few lines about that.
And we have Dr. Kaushik also commented on, I think, arterial blood gases. So
yes, I think like every abbreviations should not be used. May please mention the full form every time.
Okay, sir. Sure.
And remember, Dr. Sahana and others, if the case is comatose, you have to do some more additional steps in the management, because there is special care for comatose patient. And just remember the patient in the ICU, inside the ICU. So remember when someone enters the ICU, there's a bunch of things you have to do for this admitted patient in the ICU. So the last point in this question, so I've taken from the Oxford, and it is anywhere. So in the absence of blood sugar levels, hyperglycemic coma may be indistinguishable from hypoglycemia. So if you are in doubt, don't delay treatment with glucose or dextrose, because it will do little harm in hyperglycemia, and it is actually potentially life-saving in hypoglycemia. So remember, in the first meeting, we were talking about the hypoglycemia, and now the opposite, hyperglycemia. So if you are in doubt, if you are like at home and there is a delay in the ambulance and they have a family member with disturbed level of consciousness, diabetic patient, you should give him or her glucose, any sugary material.
Madam, may I ask a doubt? Yes, ma'am. Actually, some of my seniors who were giving me tips for the exam preparation said that in emergency medicine, I mean, I'm not sure about this, but many of them said you'll have to say that you'll call for help and then say whatever investigations you will do and how you'll manage the case. Is it relevant in every case that we ask, or should we use our instinct and answer? Like in this case, Dr. Sahana has mentioned everything perfectly, and you have corrected her whenever necessary. But should we say that I'll call for help and then start doing the evaluation?
Yeah,
is it really that important?
Yeah, it's important. Yeah, because it's always a teamwork. So call for help, call for expert in the field. So it's relevant here in general medicine and also in ophthalmology, because sometimes some cases in ophthalmic station you need for expert opinion sometimes. So it's always wise to start your answer by this, but don't stop at this point, because I call for help, I refer the patient to the cardiologist, and that's it. You have to keep going and answering what you should do. All right, Dr. Pooja. So I'm going to show you a photo and kindly comment or describe the findings, all right?
Okay.
So this is a long pause. So as I said before, you can start by saying this is an external photo. So while you are thinking, you can answer. Okay. So practice this kind of style. So while you are describing, so start your answer by something unnecessary because you are thinking. Okay.
Yes.
Yeah.
Yes. Okay. So this is
by the way, this is a difficult photo, unclear photo, and but I brought this photo for one message. So this is from irounds.com.org website. So you can start now.
Okay. This is an external photograph of the right eye, showing mild blepharitis in the eyelids, with conjunctiva being normal. The cornea shows a central scar. The dimensions probably could be around 3 by 3 millimeters.
So I want to stop you here, okay?
Okay, okay.
Because this is a diffuse illumination. So we know some challenges regarding the diffuse illumination, because sometimes you can't judge on the depth.
Right.
Okay, so you said a corneal scar. So I want to choose another participants. So stay with me, Dr. That's why I said this is a difficult question, because this is diffuse illumination, we don't have the slit. But actually, Pooja, you will not find such a photo in the exam, because it should be like clear in the exam. But actually, yes, this is the opacity, not at the level of the cornea.
Oh, okay, so it's in the lens.
Yeah, it's in the lens, but because we don't have a slit beam here. Okay.
Yes, yes. Okay.
And again, there are some reflections on the lower lid. This area is like, I will show it, I'll use a pointer. So this area, for me, because this is from the website and there is no description regarding this reflection. Okay.
Okay.
I don't know, but sometimes the polar cataract. So here, I don't know if it's anterior polar or posterior polar, but it may be like anterior polar, because in polar cataract, you may get like this different density of opacity. But if you missed this in the exam, you can justify your answer. So if you said this is a cornea, and then the examiner looks unhappy, so you can say, I want to re-verify by using the slit beams.
Okay.
So whenever you have a photo with diffuse illumination, sometimes it's hard to judge on the location of the lesion. So you have to add, I want to check by slit beams. Can you see any other things other than this opacity in the middle?
Yes, ma'am. So coming to the after cornea, I can see a large pupil, that is the iris is present only in the inferior half, and the superior part of the cornea is covered by the upper eyelid.
Okay.
So it looks like a partial aniridia. Then probably it is, I can confirm on the slit lamp, but probably this is a case with cataract in the lens.
Okay, so that's enough. Excellent, excellent. So why I brought this image, because we usually get used of seeing aniridia with red reflex, with retroillumination. But
Okay.
when we like see a photo with diffuse without red reflex, we might get confused. Okay, so get familiar with seeing like a photo for aniridia with diffuse illumination like this without red reflex and with red reflex. With red reflex, it's much easier. It's easier to pick the aniridia, but photo like this is difficult. It's hard to be seen. Okay. So now comment on this comment, because according to the experience, the candidate was asked about the genetics of aniridia. So can you comment on this slide? So what is so you will never get such a thing in exam, but we are here to focus, shed light on some important points. We try to visualize every information in your books. Okay, so this is the image of, or a photo of the picture of a chromosome, right?
So it looks like a 11th chromosome.
Okay, so this is, you said correct, 11 chromosome. And what about the P and Q here? What does it mean, P?
These are the segments of chromosome P and Q. So 11P and 11Q is what is written.
So we have, each chromosome have like a short arm and long arm, right?
Yeah.
So P for
shorter arm.
Short arm, and Q for long arm. And we have like banding on the chromosome. Okay, so as you can see here, there is 2 arrows are pointing to an area on the chromosome 11, short arm, and we have something called bands and subbands, so we have 13. So it's a chromosome 11, short arm 13. So does this mutation in this area or this gene remind you of something, Dr. Pooja?
Yes, so aniridia is because of chromosomal mutation in the PAX6 gene, which is present on 11p13.
So this number represents PAX6 gene, right?
Yes. Yes.
But since we have here 2 arrows, so actually 1 arrow is pointed to the PAX6 gene. And if you remember during your study, the PAX6 gene is
adjacent to WT1.
Excellent, excellent. So that's why there is some correlation between Wilms tumor and
aniridia. Yeah.
So here, my mnemonic, so PAX6 gene linked to the short arm is P, the small p, so we have chromosome 11. So you have to remember this sentence. Actually, the candidate, according to her experience, she was unlucky because she get a lot of questions. So one of the questions is about genetics of aniridia. So if you remember it, it will be an easy question, but if you forgot it, it will be a difficult question. So genetics also of retinoblastoma is very important. So genetics of aniridia is important, and also for retinoblastoma. So I again P here for something called paired box. So the next question: are all cases of aniridia are linked to this gene? So we can shift to Dr. Kurtana, substitute Dr. Pooja for a while. You know, Aniridia is linked to mutation in the PAX6 gene. And we have classifications for Aniridia. We will go through it in a moment, but are all cases linked to the PAX gene mutation?
No, ma'am.
No. I will stop at this answer because your answer is correct, but let's see the next slide. So as you can see in this pie chart, I want to fill up this pie chart, all information about Aniridia types. Okay, go ahead.
Ma'am, this actually the green one, I think it's 2/3 inheritance. I think it's autosomal dominant, and this, I think it should be 1/3, it should be sporadic.
2/3 of the cases are what?
2/3 of the cases are autosomal dominant, ma'am.
So in such cases, the family history is positive or negative, usually.
Family history is positive, ma'am.
And is it good to have a positive family history in Aniridia? Is it good or bad?
In Aniridia, it is good.
Why?
Because we don't have this life-threatening, this Wilms tumor in autosomal dominant cases, ma'am. Only in sporadic, we have this association.
Okay, excellent. So we'll see here so let's summarize what we have said regarding the in old Kanski, it is written like Aniridia type 1. So so like 2/3 of the cases, like 66%, with positive family history, and they are free. So it's only ocular problem. So remember, we are talking about congenital Aniridia, which is bilateral. So I use this mnemonic FFF. So F for first type, positive family history, and free from systemic implications. Excellent. Now, how about the red zone here?
It is sporadic, ma'am.
Okay. Give me more information about the sporadic Aniridia.
Okay, sporadic Aniridia is actually seen in 1/3 of the cases. And sporadic Aniridia is the one which is associated with WHGR gene because of the adjacent WT1 gene. So they are associated with Wilms tumor, Aniridia, genitourinary abnormalities, and growth retardation.
Excellent. Let's see here. So it's like 1/3, as you said. So I use this mnemonic. So SS for sporadic, severe because we have systemic implications. The old name for Weger syndrome is Miller syndrome. And you have to do screening or molecular genetic testing to search for the gene mutation in Wilms tumor. All right. And here's the narrow spectrum here.
That is the remaining percentage, ma'am. I don't remember the percentage, but the one which is autosomal recessive, inherited.
Okay. Let's see here. So it's called Gillespie syndrome. As you said, autosomal recessive. So you missed the name, but I think it's okay because you know, you remember the inheritance. We have cerebral ataxia and mental handicap or retardation. Some may not dislike the mental handicap, so you can say like deterioration of the intellectual capabilities. So you can use the euphemism here instead of mental handicap of mental retardation. So this sector actually doesn't relate it to mutation to the PAX gene. And this support your previous question, your answer. So that's why not all cases of Aniridia are due to mutation on mutation of this gene, because in Gillespie syndrome, we don't have such mutation. Okay. So one last thing here in this pie chart, we have like 33 in this red zone. 33 are sporadic, and 30% this is the incidence of Wilms tumor, and the screening start every 3 months, and then every 6 months, every year, and so on. So you may find this rule in some references. And by the way, you said it's usually said Weger syndrome. So instead of saying each letter, although the abbreviation is not recommended, but you can say it's Weger syndrome and then state each letter stands for what. So usually say it like Weger syndrome and not WAGR, as you said. Okay.
Okay, ma'am.
And I think in New Kaneskis, there is a typo mistake or like typo because it's written like WGAR. It doesn't matter, but this is the common use nomenclature for this syndrome, Weiger syndrome. So as you see here in the bottom of this slide, history is very important. So whenever you have a case of aniridia, it's very, we are talking about congenital aniridia, which is bilateral. It's very important to take a history of previous other family member having the same abnormality. Okay.
Yes.
But if the case is unilateral, you may think of traumatic causes of aniridia. So because we have traumatic causes of aniridia, which is generally mostly unilateral. And please note the color codes. So as you can see, most of the case in the green zone. So this green zone. So this is good. And here this is bad, which is red. Sporadic cases, sporadic for severe, and we need to screen, or at least do molecular genetic testing. So what does this picture remind you of, Dr. Pooja?
This is ultrasonography for probably ruling out Wilms tumor, which is common in cases of aniridia.
Yes, it's common. It's like 30% of, you have to say 30% of sporadic
30%.
cases. Okay. So just
Yes.
to visualize the importance of screening here. And this picture was taken from this video on YouTube for Wilms tumor. So this is a kind of common scenario you may get in the exam, because here is this a good photo, because we have here. So this is like classical picture of aniridia, because there is almost no rim of the iris. Okay. And we have the red reflex, and there might be something here, maybe anterior polar, posterior polar, I don't know, or Mittendorf, I don't know. But this is a common scenario, like a 15-year-old boy. It doesn't necessarily to be a child, but because it's a congenital, you know, Dr. Pooja, it's a congenital since birth, but the patient may present at adult age. But generally, in exam point of view, they present with the scenario in a child. And very important to note the bilaterality, because by definition, it is bilateral congenital aniridia.
Yes.
So what is the diagnosis? So can you again answer? It's like a rapid answer. So answer each question. What's the diagnosis?
Total aniridia.
Okay. I like your way, total aniridia, because we have a partial aniridia. So this is good. What is the genetic mutation? We already mentioned it.
Yeah, so most commonly it is with PAX6 gene mutation on chromosome 11p3.
Okay. Now read this third question. Read it loudly and answer it.
Some individuals with this condition develop an abdominal tumor. This patient's brother, mother, and grandfather all have the eye abnormality shown, which is likelihood that the patient will, what is the likelihood that the patient will develop the tumor? So if there is a family history, it's...
So don't say it like this, because the already mentioned in the question, there is family history.
What is the likelihood?
So
Okay,
this is,
so there are no chances of abdominal tumor in this case.
So this child is immune for developing Wilms tumors. There is a better answer for this, and this is actually, I brought this question, I think from Kaneskis, test yourself, something like this, because of the answer of this C, because the answer is very, very professional. So here, probably the same as general population, because nobody is immune for developing a tumor. Okay.
Yes. Okay.
So you started your answer by saying if there is family history, if there is no family history. So try to answer specifically. Try to make your answer relevant to the question, to information given in the question. So they already mentioned in the question there is positive family history. So they are talking about autosomal dominant. So instead of saying there is no risk, you can say it is as general population. So there is no additional risk.
Okay.
Okay. So back again to aniridia. So aniridia, let's talk about aniridia. So all the previous slides was like a warm up. So aniridia is a misnomer. what does it mean by this?
This means that if we do a gonioscopy, even in total aniridia, we can see a rudiment frill of iris, and therefore it is a misnomer.
Okay, excellent. So we have actually we have partial aniridia, we have complete aniridia, and even incomplete. You said if you do gonioscopy, you will see a rudimentary stump of iris.
Yes.
This is number one. Number two, so aniridia is not only about iris, right? We have a lot of a multitude of signs, ocular signs.
Yes,
right?
yes.
And now let's see the next question. It's time bound. You have 1 minute test.
Okay.
So I will present you with a diagram or like a photo of the eyeball, and you will find the numbers. Okay, I will show you. So like this one. So you have to say, so the one is pointed, the arrow is pointed to the iris, so we don't have iris in aniridia, so you can say 1 aniridia.
Aniridia, yes.
And 2, so see what the arrows is pointing and see and mention the and say the sign.
Fine. Okay.
It's all about the signs. It's all about the ocular signs in aniridia. But I want to state it by numbers. So I don't I don't I don't want you to memorize the signs of aniridia, but I want to stick to the numbers. All right.
Okay.
So are you ready?
Yeah.
Okay.
Okay. So one is aniridia. Second is the angle closure, secondary angle closure glaucoma. 3 is the lens which shows cataract and sometimes subluxation of the lens is seen. 4th is zonules, again associated with subluxation of the lens. 5 is limbus, that is the limbal stem cell deficiency is present. 6 is the cornea, which may have dryness and which may lead to epithelial defects, or because of limbal stem cell deficiency, vascularization and corneal scars in end-stage diseases. 7th is foveal hypoplasia, and 8th is optic nerve hypoplasia. Systemic is Wilms tumor, that is ultrasonography, abdominal.
Okay, the time is up. So we mentioned everything, but here, as you can see, number 8 is you have 2 arrows. So you mentioned optic disc hypoplasia, right?
And choroidal coloboma.
But
yes.
No, it's still pointing at the
optic nerve. Optic nerve, yes.
So remember, we have glaucoma.
Glaucoma, okay.
So
yes.
it's like cupping. So you search for cupping, you secondary to glaucoma, because glaucoma and aniridia is very important.
Yes.
Okay. So do you remember the incidence of glaucoma and aniridia? So I don't remember, but it's like something more than 50%.
Okay.
So you have to search for glaucomatous cupping. And you mentioned a lot of things regarding the cornea, but in summary, you can say it is aniridic keratopathy. Sometimes it's called aniridic pannus. Number 5 is limbal stem cell deficiency. As you said, this is excellent. You didn't miss it. So because you are pointing as a limbus, so you know limbal stem cells are located at the limbus. Systemic, you mentioned Wilms tumor and the other syndrome. So you can say Wager syndrome. So all the components of Wager syndrome. And number 10 is Gillespie syndrome, which is cerebellar ataxia and so on.
Okay.
So that's why we say that aniridia is actually a pan-ophthalmic ocular syndrome. We have a lot of signs in the eye. Okay. And suppose you are now we are talking about clinical station. You may get a case of aniridia with glaucoma valve or something, or with trab. So because such cases may end surgery for glaucoma or for cataract. So you may have a case of penetrating keratoplasty in aniridic patient. One last thing about the aniridia on this slide. what are the symptoms of aniridia? We have a bored child with bilateral loss of iris. What could be the symptoms in general in aniridia?
In general, a child could be brought by his parents saying that either the pupil is large or he comes with a nystagmus.
So nystagmus is important. It's pendular nystagmus because of what? Because of foveal hypoplasia.
Hypoplasia and less vision. Yes.
And because of absence of the iris, you know, iris is important for controlling the amount of light entering the eye. So they may have like photophobia and glare.
Yes.
So by the way, the incidence of glaucoma, I found it 75% of cases, and it's hard to treat.
Okay.
So this is from Kanski, test your self atlas. So match the anterior segment with the fundus.
It should be figure B.
Why?
Because I can't see the foveal reflex properly. Probably it's foveal hypoplasia, and the second image is Aniridia.
Okay, excellent. Excellent. And I think maybe there is optic nerve hypoplasia. I don't know. Is the
image is not so clear, ma'am.
Yeah, it's not clear
for the optic nerve.
But I brought this question because to remind you about the importance of fundus examination in aniridia. So it's something obvious in the anterior segment, which is the absence of the iris, but we have to check the fundus for foveal hypoplasia and optic nerve hypoplasia and optic nerve cupping. Again, you have to revise how we can diagnose a case of foveal hypoplasia and optic disc hypoplasia. Dr. Koshik, can you comment on this question so you can answer all the questions?
Like this is CRBO A and 3 NBG, neovascular glaucoma, and this is aniridia and foveal hypoplasia. Most likely there is any optic nerve hypoplasia as well, and the first case is anterior lenticulus, which is seen in Alport syndrome, and C is perimacular flex seen in Alport syndrome. This is Alport's. One is anterior lenticulus and C is perimacular flex.
Perimacular what? Flex. So the flex actually are not visible. It should be like here, right?
Yes, it's not very clear, but the shiny type of appearance can be seen.
Okay. And Dr. Rama, so this is a case of partial aniridia. And even the remaining part of the iris is atrophic. Like, so sometimes they call aniridia as a form of iris hypoplasia. So how about the second image?
Okay. This is external photograph. The cornea appears to be hazy.
Yes, why? Why you said this?
Because the the reflex is not very clear, ma'am.
Yes, it's scattered, it's irregular.
Scattered
so
reflex.
It might be the corneal edema, I don't know. Maybe high IOP, maybe.
Yes, yes. Okay.
Keep going.
I can't comment on the depth of the anterior chamber, and the lens appears to be hazy as well. Looks like immature cataract.
So I would say it's mature. Actually, I don't think we can say hazy lens, because hazy doesn't go with lenses. So we can say hazy cornea, but hazy lens. We can say, just say cataract. So what else?
Okay, the lens appears cataractous, and the limbus probably
maybe
is,
maybe there's some panas.
Could be some. Yes.
Again, this is from Kanski, and because it's old book, so the pictures are not clear. Here, I want to say something. You can ask the examiner, I want to check the other eye. So what is the importance of checking the other eye? Because this could be a traumatic aniridia. Okay, other eye is very important point to be asked in the history. What is the condition of the other eye? Is this iris, this condition since birth or acquired? Because again, when it comes to aniridia, we have a traumatic causes for aniridia. Okay.
Yes, ma'am.
So according to the reference, this is superior subluxated cataractous lens in Aniridia.
Dr. Ghada,
Yes.
actually, I think the cataract is superiorly subluxated, which is typically seen in like congenital aniridia. And this inferior clear part is like there is a deep aphakic portion, and this is aniridia. There is peripheral some part of some iris is visible, but this is the whitish part. The lens is superiorly shifted. Cataractous lens is superiorly shifted, and inferiorly we are seeing the glow. And also I think the limbus is not normal. There is some limbal stem cell deficiency. And yes, maybe the cornea the light reflex is not sharp, which may be due to increased intracranial pressure, or there is some TRPM instability, or just patient has not blinked the eye.
Yes.
But this appears to be congenital aniridia to me, because superior subluxation is typically seen. Like if there is subluxation in congenital aniridia, mostly the lens is shifted superiorly, and also there is some limbal stem cell problem in this case.
So you see, two sets of eyes are better than one set of eye. So this is actually the red reflex, and that's why now it's visible. So this is superior subluxation. So this is actually a total aniridia, not partial aniridia.
Yes, ma'am.
Thank you, Dr. Kaushik. Thank you so much. One of the points to be mentioned in Aniridia is gonioscopy. So this is this is from eopthal.com, the normal anatomy of the angle. So can you say it, Dr. Rama, from anterior to posterior, the normal structures?
I mean, okay. So
I'm using the pointer.
Starting from the shawl base line, which is the peripheral termination of descent membrane. Then Schlemm canal.
So remember, when you are examining, when you're doing gonioscopy, so there are a number of, so there are some pigmented structures and non-pigmented structures, right? So this is a trabecular meshwork, because this trabecular, it's pigmented, right, Dr. Rama?
Yes, ma'am.
And then after trabecular meshwork, what we have?
In the trabecular meshwork can be anterior and posterior. Posterior is pigmented, and after that, then there is Schlemm's canal and scleral spur.
So scleral spur is white, as I'm drawing.
White,
down.
Yes.
Okay.
And followed by the ciliary body band.
So again, the ciliary body is
pigmented.
So as you can see here, the iris root is attached to the, let's say, in the center of this ciliary face. So we have like a ciliary band here. Okay. So generally, the scleral spur is white and visible. Something in front of it is trabecular meshwork pigmented, and something behind it is something pigmented, is ciliary band. All right. So this is the normal gonioscopy, normal angle. So this is the iris, and this is the back of the cornea. So now what is this? This is a normal. So this is a ciliary band, and this is the trabecular meshwork here. So this is the two big pigmented bands, and in between is a white line, or white area is the scleral spur. So before you study the abnormal angle, you have to know the normal angle. Okay. So back again to this diagram. So normally, Dr. Rama, normally we cannot see the ciliary processes or the processes, because it is obscured by the iris. So in normal gonioscopy, we couldn't see the ciliary processes. But how about this one? Now the ciliary processes are visible. Why?
Yes, ma'am, because there is no iris in this picture.
Oh.
It's just the rudimentary iris roots which are seen.
Okay, so
in case of Aniridia.
So in case of Aniridia, you can see the ciliary processes because there is no iris obscuring the view of the ciliary processes. Okay, and remember the quiz I posted on WhatsApp. Here, this is in this gonioscopy we have an iris, but this iris is separated from the ciliary body. So this is iridodialysis again. So you have two conditions where you can see the ciliary processes on gonioscopy: absence of the iris or separation of the iris from the ciliary band. And some of you also commented on this gonioscopy because this is a trauma case. So we have also a ciliary angle, what we call it, angle recession, because the ciliary band here is visible and widened. So again to this photo. So try to remember that normally you can see the ciliary band like a smooth band, this area. Okay, but normally you can't see the ciliary processes or processes. Got it? I just wanted to stress on this point. And this is a wonderful website to learn everything about gonioscopy. So Dr. Kaushik just sent a website. I don't know if you can check it right now.
Yes, it's like we had written a like an article on Aniridia. People who are interested, they can read this.
This one?
Yes.
It's very recent. Okay. It's like a review article, Dr. Kaushik.
Yes,
right?
yes. This is
Okay.
this is a article on this.
Okay, you can send it on the WhatsApp because sometimes the chat is lost once we end the meeting.
I'll share the link.
Thank you. Okay, so can you please comment on this photo?
This is a color photo of the anterior segment of the eye, and this is taken under slit lamp illumination. I think it's broad beam illumination. The cornea appears to be hazy with the vascularization over the cornea.
Mm-hmm.
And this is a retro illumination, I think.
Yes, it's retro illumination.
Retro illumination.
So you see now, actually it's a case of Aniridia, but because of the corneal problem, it's becoming hard to pick it. But it's now, if you can see, there is no iris. So again, you have to get used of seeing Aniridia with other conditions, with other ocular signs. So this is actually, we can say it aniridic keratopathy or aniridic associated keratopathy or corneal panas because of the limbal stem cell deficiency. So these cases might need in the future penetrating keratoplasty. So you can see here, I wrote like dots and then etc. So because they may also need keratoprosthesis because we have a problem in, so sometimes the cases is very advanced. All right, Dr. Tamanna, and this is a reminder of the normal limbus. So this is, so do you remember the name of these structures? You know, this is striation.
Palisades of Vogt.
Yes, excellent.
Palisades of Vogt.
Yes, excellent. So this is where the limbal systems reside, and you can appreciate this if you examine the patients meticulously or even normal subjects, especially pigmented subjects. So do you have other comment on this photo? This one, other than, so I brought this image because of Palisades of Vogt, the normal appearance. Do you have any other sign Can you see any other sign?
Here on the superior aspect, I can see the sutures, and also the graft whose junction. So probably this is a keratoplasty. The patient has undergone keratoplasty.
So excellent. So here actually this is a case underwent keratoplasty, but with normal limbus. So Dr. Tamanna, stay with us. We have a rapid fire questions about the Aniridia. I think we already answered a lot of them, but it is like a practice for you.
Okay.
So what's the hallmark of Aniridia? So again, we are talking about congenital Aniridia. What's the hallmark?
Absence of iris.
Yes, absence of iris. So are all cases congenital?
It can be sporadic also.
So sporadic.
Okay. It can be traumatic.
Yes,
so it needn't be
yes.
congenital all the time. Sorry.
Okay, this could be traumatic. So again, you can add more and like stay professional by saying traumatic. It could be trauma, like accidental trauma or iatrogenic trauma. So, you know, sometimes it happens during surgery, especially if you are doing stretching of the iris or excessive manipulation of the iris. Because the iris attachment to ciliary body is a weak point, because whenever we have a transition between one structure to another structure, we can get separation. That's why we have iridodialysis, we have retinal dialysis, and even with blunt trauma, we have rupture of the globe at the limbus, because limbus is an area of transition between the cornea and the sclera. This is a weak point. Excellent. So what are the symptoms? You can repeat it again.
There can be photophobia, large pupil, and nystagmus.
Okay.
Hello.
This is like a basic symptoms. Yeah, excellent. What surgery they might undergo, or so some aniridic patients may need surgery in the future because of what?
Yes, they might have to undergo cataract surgery or a keratoplastic surgery, or even a goniotomy or trabeculectomy or glaucoma drainage device.
Yes.
This is for the control of IOP.
So remember, in clinical station, we may have like a combo cases, like an aniridic patient with glaucoma signs or glaucoma operation. So they might underwent something for the cornea, something for the lens, or something for the IOP. All right. What is the benefit of prosthesis? Prosthesis, I mean here by prosthesis, the iris prosthesis.
You can give painted contact lenses.
Oh, this is the least, the least invasive method. So if a patient is complaining of photophobia, you may start by contact lenses, and then another surgical approach would be
then tinted IOLs can be given.
Yes, tinted IOLs. So all of because of photophobia. So this is a benefit. What are the causes of loss of vision in an aniridic patient? So I mean here by loss of vision, diminution of vision. So loss of vision doesn't always mean no PL. Generally, it means diminution of vision.
So there can be refractive errors, amblyopia, squint. Then coming to the corneal aspect, there can be keratopathy, then cataract. Then there can be foveal hypoplasia, optic nerve hypoplasia. Yeah, these are some of the things that can cause diminution of vision.
So there are many causes for loss of vision. So according to this reference, it is divided into early and late. So very important, the hypoplasia, foveal and disc, and secondary nystagmus. So nystagmus per se, because of loss of foveation time, can cause additional factor for loss of vision. And later on, remember, the glaucoma in aniridia is not early onset. It's like juvenile or like So it is not, usually it doesn't cause ophthalmos, I believe. All right. Let's see. Last thing with you, Dr. Tamanna. So here in this slide, it's all about Aniridia. So let's see this one. What is unique about this case? So
this case, the patient has undergone keratoplasty.
So we have
So-
keratoplasty. This is one sign.
And also it's his pseudophakic.
Yes, pseudophakia. And how about this iris?
Iris hypoplasia.
Okay, this is actually an artificial iris. So this is an artificial iris. It's not a true iris. And they call it prosthesis, like ocular prosthesis for iris. Again, for photophobia. But in this, and this is the same, the artificial iris, but here there is a pattern. So it looks like a normal iris, but this is actually an artificial iris. And this is another form of artificial iris. And this is the one you mentioned, like IOL. So we have the IOL with opaque periphery. It's aniridic IOL. And this is another case of aniridia undergone keratoplasty, but you see here, because there is no red reflex, it's unclear. I don't know if Dr. Koshik can add something, but there is an edge here. So according to this reference,
it's a lens subluxation.
Because it looks like a pseudophakic patient, because this is, I don't know, it's a pseudophakic or clear lens subluxation. But the most obvious sign is there is a keratoplasty.
Yes, I think this is a keratoplasty patient, and this is pseudophakia. I think this sign at the margin, such sign at the margin is very difficult to see in normal phakic patient. And the size is also less, like the AP it would have been lens, it would have been at least 10 to 11 millimeter diameter. But this thing inside what is seen, it is very small in diameter.
Okay,
I think this is pseudophakic eye with which has undergone PK and the sutures have been removed.
Thank you, Dr. Koshik. So the reflection actually goes with the IOL, and Dr. Koshik mentioned also the size. We went through this slide before, Dr. Tamanna. Remember, I think you answered this question, causes of ectopia lens. So as you can see here, aniridia is among the causes of congenital ectopia lens. So in aniridia, we may have cataract or subluxation or dislocation. And so this slide is very important. The ectopia lens is a very important topic, and the causes, especially those with syndromes. And please don't forget the acquired causes. And among the acquired causes, the anterior uveal tumor or cerebral body tumors is important. Again, iatrogenic belongs to trauma, spherophakia and microspherophakia. So this in yellow, we missed to say it last time. So that's why I repeated this slide. But because last time it was oral, but here it is written on the slide. And according to nomenclature, we have ectopia lentis. It could be total, we call it luxation or dislocation, or it could be partial, it means subluxation. And we went through this, and already is misnomer, and we have a lot of list for misnomers in ophthalmology. But because we are in rush now, we can say only other three. So do you have other misnomers in ophthalmology? So anyone can participate now.
Aniridia is because there is almost always there is a stump of iris, and it is not full absence of iris. So this is why this is Aniridia is a misnomer.
Yes.
Ectropion EVE, like ectropion EVE is a misnomer.
Pyogenic granuloma, ma'am.
Pyogenic granuloma, this is one. This is neither granuloma nor pyogenic. Another thing. Okay, so retinitis pigmentosa, Dr. Koshik. So retinitis pigmentosa is easy one. So it is a dystrophy or degeneration, not inflammation. And many others. There is a lot of misnomers. The next slide is like a game or like again. So it's under the theme or under the title. We can't see this unless. Let's explain. We can't see this unless. So we can't see the lens equator or zonules, even with a fully dilated pupil, unless. Hello, everyone.
There is lens subluxation.
Yes, yes. So tamanna. So this is unless there is lens subluxation. So we can see the equator. We can't see the ciliary processes on gonioscopy unless.
There is Aniridia.
So Aniridia or iridolysis. Okay. We can't see the Schwalbe's line unless. So we can't see the Schwalbe's lines from the anterior segment from like
posterior embryotoxin.
Posterior embryotoxin.
Yes, unless we have a posterior embryotoxin. And we can't see the optic nerve myelination unless. It's easy.
Myelinated nerve fibers.
Yes, excellent. So myelinated nerve fibers. So this is subject. Excellent, excellent. So all what we have mentioned, you have to study. So I will study myelinated nerve. It's a very important topic, and you have to study everything in the GAPC. Okay, let's see the quiz here. Okay, so Dr. Aricia, please comment on this photo.
Ma'am, this is an anterior segment. This is a photograph on an eye showing conjunctiva and the anterior segment. The cornea looks clear. However, there are some suture marks which are seen on the, I think, the temporal side. And there is iris stumps are visible. So there is Aniridia.
Okay, that's enough. Very well that you mentioned the suture lines, the scars of the suture lines of most probably keratoplasty, penetrating keratoplasty, let's say. So we have like a cases of previously operated keratoplasty, okay? But in the last meeting, I mentioned that we might confuse between Aniridia and a fully dilated pupil. So again, this photo quiz is not meant to challenge you or to, but I have a message in this photo because sometimes we might confuse between images. So if you notice this, there is a rim of the iris, but the iris actually looks healthy. And if you are confused whether it is Aniridia or fully dilated pupil, you can mention this to the examiner. So I can't decide is it a fully dilated pupil or Aniridia. So actually, this is a case. So Aricia, stay with me. This is a case of a fully dilated pupil, and it is fixed after penetrating keratoplasty. So what is your diagnosis? Again, this is a case of dilated fixed pupil after penetrating keratoplasty. So we have a name for this complication because this is actually a complication. If you get a fully dilated pupil after, this is not.
Ewell-Zerata.
Yes, excellent. So here, this is Ewell-Zerata syndrome. And this is again a case of Ewell-Zerata syndrome, but without reed reflex. And if you remember, it looks like Aniridia, but this is not Aniridia. Yes. So actually, a pseudophakic patient with like underwent penetrating keratoplasty. And I will show you, this is a hyperlink So just remember this photo, and this is for actually for Uris-Zavalia syndrome, and here is the hyperlink. This is an Aniridia patient. So they look similar, I think.
Yes.
Okay. So do not let your performance in each station affect you in the next one. Have a fresh start for each station. And try to stay positive. Sometimes I hate this word, but it's a good word. It's a good advice. Thank you so much. I think this leads us to the end of this presentation. So does anyone have any question or any comment before I end this presentation, this meeting? No?
Excuse me, ma'am.
Yes.
How do we distinguish on gonioscopy between angle recession and the iridodialysis?
Okay, all right. So I will go back to the slide. 1 second.
Yeah.
So just remember the anatomy. All right. So let's see. So what is the definition of iridodialysis? It's like separation. Yeah, it's like separation here. There is like a full thickness separation of the iris root from the ciliary body. So that's why I like erased this part of the iris. Okay, and the iris will be like falling away. All right, Dr. Arisha. Yes, so actually in you don't need gonioscopy to diagnose iridodialysis because it's visible without gonioscopy, but we sometimes need to do gonioscopy in iridodialysis to see to exclude the presence of angle recession, because you know it's all about blunt trauma to the eye. So generally the cause is blunt trauma of the eye. So blunt trauma can cause angle recession, can cause iridodialysis, and so on. So so in iridodialysis, first of all, you will notice the iridodialysis on the slit lamp, like external view. But if you do gonioscopy, since the iris is separated from the ciliary here, you will see the ciliary processes, because it's now you can appreciate the presence of ciliary processes. Okay.
So, ma'am, ciliary processes will be seen in both iridodialysis and angle recession.
No. 1 second. So, so in iridodialysis, this let's see, draw this one. So you are observing right now here on gonioscopy, you will appreciate the presence of ciliary processes in iridodialysis. So if the case is iridodialysis only, okay? So imagine now we don't have iridodialysis, and the patient underwent trauma and hyphema, the hyphema resolved, and you want to do gonioscopy to check for angle recession. So do you remember the definition of angle recession?
Separation between the ciliary bodies, longitudinal and the circular muscles, separation of the ciliary body band.
So the lesion is there in this area. In this area.
Yes.
There is separation here. So what is the result? The result is that you will get a wide, like a wide band of the ciliary, the smooth part of the ciliary band. So the ciliary band is like widened. Okay. And because of this separation in here, again the iris is somehow fall back. The iris somehow fall back because the iris is attached to this area. So the angle looks wider, and the ciliary band is wider. Okay. But you cannot see the ciliary processes. So back again to this slide. So in this slide, you are seeing, so this is the, let's use a pen. You see this? This is the trabecular meshwork, the pigmented trabecular meshwork. And this is the white band here, this clear sphere. Okay? And this area is a part of the ciliary band. But we see also the ciliary processes is also there, because there is no iris here obscuring the ciliary processes. Okay? So,
Yes,
but here, the iris is there. This is the iris. And it is separated from the ciliary band is widened here. So this is the ciliary band. The smooth part of ciliary band here is widened. So since the ciliary band is widened, so there is an angle recession. And since there is ciliary processes is visible because these processes are visible because of the iris is separated. So we have two signs here: angle recession because of widening of the ciliary band, and there is disturbed anatomy here. This is like something irregular here.
Yes, ma'am.
And because of iridialysis, we can see also the ciliary processes.
Thank you, ma'am.
You're welcome. All right. Thank you all, and have a good evening.